postgraduate faculty on the Department of Community Medicine. And so this training program is based on the competency-based dynamic curriculum, the PG program. Today, this is the second day of the series of the training program, and today this is the second session. And we are lucky to have Dr. Prashant Rath sir to share his valuable knowledge, and because he is one of the most educated person in the field of community medicine. And the question is that there are many confusions, many such uncertainty regarding the EPA, the subject, the paper pattern, and the academic execution. We hope that in this session, after listening to sir, we can enrich ourselves, and it will be beneficial for all the faculty members to carry forward the curriculum in a fruitful manner. So with this word, I extend my sincere gratitude to Prashant Rath sir. Sir, good afternoon again. And I would like to convey the microphone to you, sir, to take forward the today's session. Sir, over to Prashant Rath sir.
Thank you very much. Thank you for the introductory remarks. President Dr. Rajat Chattopadhyay and members of NCH, I am thankful to them for giving me this opportunity to share his views on MD Homeopathy Community Medicine curriculum document. And let me present my presentation. If you have any difficulties, we will discuss that after I finish my presentation. There is some hope. Can we manage? Anyhow, MD Homeopathy Community Medicine curriculum documents that we as you all know, it is consisting of two parts, part 1 and part 2. Like any other subject, part 1 has got 3 papers: fundamentals of community medicine, fundamentals of clinical medicine in community medicine, and research medicine in biostatistics. This third paper actually dealt separately by research methodology department, so we will discuss this today. And the remaining 2 things, the second part is community medicine paper 1 and community medicine paper 2. So the whole curriculum has been divided into 2 parts, the part 1 and part 2. Part 1, 3 papers. We will discuss about 2 papers, and the remaining 1 paper we are not going to discuss. Part 2 also, paper 1, paper 2, like any other subject in MD Homeopathy curriculum. So, coming to the description and relevance of course in community medicine, we are discussing about the objectives and what the students will learn. That is given in the introductory part. Basically, our aim is to produce expert clinicians, expert academicians, and expert researchers in this field of community. So, if you want to make our students once they pass out from MD Homeopathy Community Medicine, then we should be very good clinician who will be practicing based on evidence-based medicine, and academicians with who will be using the modern teaching learning methods, and they will be good researchers, innovative scientific ideas, and implementing it in the field level. Then coming to what we are intending our students to learn, they will be able to plan, implement, and evaluate business projects using the recent advancement in health and technology and technology, and our focus will be on promotive, preventive care rather than treatment, because physically we are dealing with complications. So, community medicine is to start in the community rather than in the classroom. That should be our emphasis. So, we should expose our students as much as possible to this and then public health potential of homeopathy needs to be tapped, generating evidence. what are interesting professional activities. If you go through this curriculum, you will find that everywhere they have mentioned about ETAs. ETAs are basically suitable professional activities, and all of you know that interestable professional activities are the key professional tasks that a medical graduate should be able to perform independently on sufficient competencies achieved. Just a minute. The competencies describe abilities, case describe actual and in practice. So basically, we are expecting that the students will be performing certain professional tasks, and to do that, they should have basic abilities. So those abilities are basically competencies, whereas the activities they will be carrying out are interested professional activities. Then they should be able to conduct community health education. Say, for example, they should be able to conduct community health education sessions independently and communicate effectively with patients and families. So the competencies are the student communicates effectively with patients and families. What are these four characteristics of the ATA? If you see, like previous curriculum and this present curriculum, everywhere they divided this post curriculum into different APAs. That is interestable professional activity. What are these EPAs? We should be very clear about this. These EPAs are nothing but like observable, measurable, independently executable, professionally relevant, integrative, and observable means faculty can directly observe the performance. Measurable means performance can be assessed. Third thing is independently executable. Learner can perform with increasing supervision. Professionally relevant means reflects real life practice. Integrative combines multiple competencies, and interested supervisors can decide the level of process. That is the basic core characteristic of APAs. Say, for example, we want our students that they should be able to perform certain research activities in the field. So basically, they should have a prior participation in such kind of activities where they are just observe the things. Second thing, they will be involved in such kind of activities. Third thing is they will be independently planning and able to execute them in the field. That is what is actually the interestable professional activities. So if you see the difference between traditional teaching and EPS, traditional teachings are based only on theory and recall of facts. And there was an examination to evaluate the system, and that is how we could decide what the student will be able to perform. Whereas EPS are real world performance, accountability, integration of knowledge, skill, and attitude, ethics, and communicates workplace-based assessment. The CPAs answer the question: can this learner be trusted to perform this public health activity independently? If you expect students to perform such activities, then we should have prior exposure and under certain guidances, and slowly that guidance, once we remove those guidance, whether they can do it or not. Why these EPAs are important in community medicine? Because community medicine is a practice-oriented discipline where we focus on preventive care, public health actions, epidemiology, and community health, national health programs, and health management. Coming to the relationship between EPAs and these competencies, the core competencies for any domain is knowledge, skill, communication, professionalism, ethics. So if you see, suppose the EPA is to conduct an outbreak investigation, then or provide anti-rating counseling and analyze surveillance data. The corresponding competencies will be communication, epidemiology, data set, techniques. Provide antenatal counseling skills, knowledge regarding preventive medicine, and analyzing of surveillance data. The student should have ability of data analysis, biostatistics, and interpretation. Coming to the EPA in community medicine, let us take some examples so this becomes very clear. Say for example, the EPA is community diagnosis. The explanation for this EPA will be conducts a family health assessment and prepares community diagnosis. The student should be able to conduct community surveys, assess health needs, identify determinants of disease, and interpret demographic indicators. Say for example, we want our students to go to any village and find out what type of disease is prevalent there and what necessary measures can be taken to decrease those disease conditions like disease. Similarly, to perform an outbreak investigation and prepare an epidemiological report, the students should be able to know, identify the outbreak, define a case, define the cases, calculate alternatives, and recommend control measures. This is a summary. Similarly, for national health program implementation, the students should be able to understand program logistics, monitor indicators, and conduct the field implementation. Say for example, we want to conduct an immunization session. In that case, what all logistics are required and how we can see that the immunization really decreases the prevalence of childhood diseases and conduct field level implementation, like how the immunization systems can be conducted at rural areas. Then health education and communication. The EPA will be conduct community-based health education sessions, like deliver health talks, counsel individual and groups, conduct IEC activities. That is information, education, and communication, behavioral activities. Coming to maternal and child health, the students should be able to assess high-risk pregnancies, counsel the mothers, monitor the growth chart, and promote. So, I hope you better understand what actually EPA is. The whole course curriculum has been divided into different interest-level professional activities. And under each EPA, there are certain activities that the students should be able to conduct. That is, say for example, departmental and occupational health. He will be able to assess the sanitation. He will be able to evaluate the water quality and identify some others. Similarly, for public health surveillance, the student should be able to collect, interpret surveillance data, detect trends, and report notification changes. Similarly, for research method and biostatistics, So students should be able to design research, analyze data, interpret the results critically. But to achieve these interestable professional activities, the students take some time. It's a continuous process. We cannot expect the students to achieve these activities or abilities overnight. It will take some time. So what they have done is each interestable professional activity has been divided into levels. The first level is the student will observe only. There is no permission to act. Similarly, performs with direct supervision. Third thing is performs indirect supervision. Fourth is performs independently. And fifth is supervisor judgment. That means initially he will only make observations. Second, he will be performing under direct supervision. Say, for example, during our COVID-19 pandemic, we have taken our HMS as well as PG students to field work, and so they performed under direct supervision. Then performance under indirect supervision is like you involve them in planning and planning process, and then like you can send them to the field and see whether they are doing performing well in the field or not. You can monitor them from a distance. That is performs with indirect supervision. And fourth thing is performs independently. That means he should be well trained so that he doesn't require any supervision. And ultimate in expectation from our student is the students should be able to guide the juniors. So there are different levels of entrustment. These entrustments are typically done by the teachers or guides. So they should decide which student requires only observation or how many of them can perform the direct supervision or whether he is able to do it indirect supervision and performs independently or he can guide others. The ultimate aim is to make the students able to guide juniors. So this APF framework lifting cognitive medicine aims at clinical exposure, skill-based learning, skill-based activity, and there are integration at different levels. And there are reflective learning. Say for example, once they have conducted a study, they should they should reflect on what else could have been done or how to improve the previous work. So this reflective learning will give them they take on lifelong learning, learn and perform, and then reflect upon what they have performed, and then they can improve upon the previous one. And this is a complete assessment that can be done by the and EPS is professionally is say for example this interestable professional activities, what all tasks are included, and then what competencies are integrated on that task, how you are going to assess them, and what entrustment decision can be taken in practice. Say for example, same outbreak investigation if you take, will be able to verify the diagnosis, found that out, prepare the case, collect the data, analyze the epidemic, recommend the control measures, communicate findings. Then competencies integrated are he should have the knowledge regarding epidemiology, should have good communication skills, he should have leadership skills and teamwork, and he should have ethical knowledge and data interpretation abilities. So basically the abilities are the competencies and the tasks are performing are interestable professional activity. And the entrustment is the responsibility of the faculty. Whether they need supervision, they can perform independently. or supervised service. Next thing is these are the various assessment methods that is being used for the course. It can be mini clinical examination, direct observation of procedural skills, can ask them to perform certain things and you can observe them. And field observation, like what activities they do at the community level, and they can be longitudinal learning evidence. They should maintain a logbook for documentation of the skills and reflective writing, attitude and professional visit, and tracing feedback. That is team behavior. That is, if all the workers, including the faculties, they will give feedback regarding the performance of the students. Then advantage of EPA in community medicine is this is practice oriented. We have better accountability. It ensures that graduates are is ready. And third thing is integration of different domains like knowledge, skills, and attitudes, improve assessment, moves beyond theory and examination, and enhance public health preparedness so that they can independently handle outbreaks, disasters, health programs, or surveillance. These are the biggest advantages of APAs. And then challenges are like packages, its orientation, it's a time-intensive assessment, lot of documentation needs to be done, large student numbers, it is difficult to individualize the assessment, and subjectivity assessment decision made by the faculty. So EPA comes from the community medicine education from body public health, public health, safety, and impact. More subjectives like all the EPS involved in MD community medicine. There are 20 EPS, and these are the list of EPS. You can see this EPS, understand the concept of different diseases, relate them to the concepts of health and disease from different system of medicine, including homeopathy and other system of medicine. Identify individual community health problems, do community diagnosis as per animal concern, prioritize each problems of community through study of community susceptibility. The third is the identify fundamental and exciting and material process of the disease at individual and community. Learn, implement, and evaluate any action aimed at and status of community animal concerns. Similarly, other APIs are like establish a system to collect health data from the community based on animal and formally put action based on this community. Do epidemic investigation for homeopathy concept and effectively apply epidemic plan and conduct derive evidence from research studies as per internationally accepted norms to generate evidence from homeopathic system. Like they will conduct various research studies and those research studies needs to be published, and so that we can generate evidences for our homeopathic system. Critically analyze the relevant research publications aimed at generating evidence of homeopathic system. So similarly, there are 28 APIs that have been listed in the module. These are the various things. So I'm just skipping them so that we can have more time for discussion. Use various teaching learning techniques for imparting undergraduate 2026. Understand also the applicable health laws and regulations at international, national, local levels. Understand role of environment health and disease transfer homeopathic concepts and identify local environmental factors including external disease, projection as per homeopathic concepts, and can plan and implement control and corrective measures of environmental factors and debtors. Can effectively manage all aspects of healthcare facilities, providing primary, secondary, tertiary. Like that, there are 28 EPAs that are mapped. And for these EPAs, the core competencies that are required may not be all the six. There are six core competencies that are described. First thing is the knowledge, basic theoretical knowledge, concepts, and then patient care, take the essential ability to derive the various signs and symptoms from the patients as well as from the communities, and then homeopathic orientation, communication skills, practice-based knowledge, and strengths. These are the six core competencies. Each can be applied to each and every EPS, but not necessarily that all the competencies are required for each of the EPS. Say, for example, we are discussing about history of medicine. They are mostly will be dealing with the knowledge and scholarship. Okay. And when making homeopathic orientation, but patient care are not so much used. This is how they are planned. First, we understand homeopathic concepts of health and disease and relate the concept of health and disease from different. If you see, there is knowledge and scholarship and homeopathic orientation. Other key competencies are not there. Similarly, every competencies have been mapped based on these six core competencies. Domain competencies. Then I told you that these abilities do not develop overnight. So what they have done is they have needed them where the student requires only observation, where he needs perform under direct supervision, performs with indirect supervision, performs independently and supervision. So to go to the fifth thing, it requires that he has gone through the previous things. So what they have done is based on each and every semester, they have mentioned the levels 1, 2, 3. So if you see semester 1, he will observe the academic investigation. Semester 2, assist in academic investigation. Third is do under supervision of academic investigation. And fourth level is do under supervision academic investigation. That will continue in the fourth semester also. And fifth semester also that will continue. And ultimately, sixth semester, he can do it under supervision and if required, he can do it independently once the course is completed. So that is how there are different levels of interest rate which will be not different semesters. So semester wise, EPA levels are applicable to each level. Then comes to the right video, we have formative and summative assessment. And this formative assessment and summative assessments we have divided what all chapters will be covered under part 1 and part 2. And each subject is again divided to sub-components. And this is how they have described each individual EPA to knowledge, skill and reference. See, one EPA can cover more than 1 or 2 competencies, and each competency again divided into knowledge, skill and reference. So he will know what is to be done, then he will do it. So what are skills are required to perform those activities, and he will reflect on the activities so that it will complete the learning cycle. So that again he will improve upon his previous work. This is how it has been done for each of these EPS. Yes, coming to the assessment, I told you there will be 2 term tests. Okay, 1 term test for each semester, and 2 term tests are over. Each term test will be under 6 months. For 6 months first term, then 12 months second term, and 18th the MD Part 1 examination. For MD Part 1 examination, like I told you, there will be 3 papers. One is fundamentals of community medicine, which will be 100 marks, pass mark will be 50, and second paper also 100 marks, pass mark is 50. Research methodology 100 marks, pass mark is 50. For research method, there is no practical examination, whereas for other 2 papers, there will be combined practical or clinical examination. And out of this practical, the 2 top tests, they will also contribute to this practical or clinical. Is that 20% marks will be there from the top test. So out of 200 marks, 40 marks will be from the formative assessment, that is top. And top test will be practical examination and will be no theory. So out of this 200, 40 marks will be the internal assessment and 160 will be summative assessment. And the student should secure 80 marks in this 160 marks in the internal assessment. Then for the theory, the blueprint for the theory, there will be one problem based question, which will be of 20 marks, and there will be 4 long answer questions, bearing 10 marks each. So that will be 40 marks, and then short answer question will be 8 short answer questions, each having 5 marks. So total is 20 marks. So altogether 10 marks. This is like any other MD Part 1 examinations. The blueprint, like all the chapters will be covered in the Part 1. They are also, so accordingly, questions are from this chapter. Coming to the internal assessment, there will be 50 marks. This is for clinical assessment. Out of that practical, 20 marks will be internal assessment. One long case will be 30 marks. One short case will be 20 marks, and 5 marks, and micro case 5 marks, 100 marks. For Viva, there will be internal assessment 20 marks, and discussion of 30 marks, Viva 60 marks, 100 marks. Similarly, for Part 2, there will be 2 papers. Unlike Part 1, there are 3 parts papers. The third paper I told you will be research methodology and statistics, and that will be taken by a separate research methodology topic. And the other 2 papers we have already discussed what all topics will be covered. Similarly, for Part 2, there will be paper 1 and paper 2. And there these are the distribution of papers. Like chapters are under each paper. And similarly, for there will be paper 2. This is one of the examples like how the topics for Part 2 will be. Again, same feel and reflection, and what are the content methods they will be using, the assessment method, and same text and competencies. This is how they are distributed. For Part 2 examination, after Part 1 examination, the second top test that will be during the 30th month, and during 36 months there will be community. So every 6 months there will be a top test, and 1.5 years, and after the completion of 3 years, will be Part 1. And maximum marks for each subject, maximum marks equal to pass will be 100 marks for paper 1, 100 marks for paper 2, and pass marks are 50. And similarly, like Part 1, have a practical and viva work consisting of 200 marks. 30 marks will be contributed by your internal assessment, 160 marks or your practical viva examination. Similarly, the pattern is also remains same: 1 problem-based question, then 4 long answer questions, and 8 short answer questions. The problem-based question carries 20 marks, long answer question carries 10 marks each, and short answer question carries 5 marks. So totally 100 marks. And this is how the different topics have been allotted. Part easy, part 2. Similarly for paper. For part 1, paper 2, which is fundamentals of clinical medicine in the field of postgraduate community medicine. There also we have described the EPCs based on knowledge, skill, and reflexes, and then the paper. Here also it is 100 marks, 50 pass mark, and the Viva is combined. Thank you very much. I think I finished. Anybody is having any question, they can. So basically, the most curriculum has been divided into skills and competencies and different level of interest.
Hello, Prashant sir. You can unshare your screen.
Yes, yes.
You can unshare your screen, sir. Yeah. दबाइए.
This is all about from my side. If you want to ask anything, you can ask.
You can say if anyone. If anyone wants to ask any question, please raise your hand. Sir will repeat your question sadly. Okay. So after the session, I think no one have any confusion. I will hand over the session to President Dr. Rajat Chakrabarty, sir, President of HCB. Sir.
Many thanks, Professor Dr. Prashant Roth, for nice deliberation, whatever I've gone through also. I think all the esteemed professors, the faculties concerned, they have very good interaction with Dr. Roth. And if anyone having any confusion or any question, any doubt regarding anything, regarding paper setting or examination part or regarding EPA implementation or anything, concept, whatever, they may feel free to contact us, to contact HEB, Homoeopathic Education Board, at our email. You can write anything as whatever your feedback or whatever your confusion, any doubt. We will send it, any doubt or any question or any confusion, we will send it to our expert, and then you will be answered all. So this is the first beginning, and it's a very first session on PG, this community medicine. And I also convey my thanks, many thanks to Dr. Prashant Roth. Within a very short period of time, he agreed to be a trainer of this session, and this is the beginning. So we will be continuing this whenever it will be implementing in the MD part 1, after part 1, part 2, after one full session, we can, I think you also can rather experience that what problem we are facing or we will be facing, and accordingly we can make it, the confusion or doubt may be cleared. If any modification required, that can be done with the time. And ACB, National Commission for Homeopathy, always with all the faculty, esteemed faculties, for clearing any of their confusion or doubts. So I again convey my thanks to the trainer and all the attended faculties. If I am not right now, I am not seeing any raised hands. So I think Dr. Roth nicely elaborated and presentation was so good that not a single confusion or a single raising hand I can see. So this is the end of this session. We will be meeting soon. Thank you.
Okay. Thank you, sir. Thank you very much.
Thank you so much, Prasanta and Rajat sir. It's very good presentation, and we have undergone the training again.